Dear Heavenly Father, we ask you to give us your guidance over our decisions that we make for our people here at the Cherokee Nation. We ask that you watch over our troops that are overseas and serving our countries. Bless the Cherokee Nation, and we ask all of this in Christ's name. Amen.
Amen. Next with roll call, please let us know you're here.
Bradley Cobb.
Honey.
Janelle Fulbright. Bill England. Bill John Baker.
Here.
Jack Baker.
Here.
Harley Buzzard.
Here.
Julia Coates. Here. Joe Crittenden. Jody Fishinghawk. Meredith Braley. Dawn Garvin. Hannah Glory Jordan. Curtis Snell.
Here.
Chuck Hoskin Jr. Chris Soap.
Here.
David Thornton. Kara Callan Watts.
Honey.
We have one.
Next on the agenda was approval of the special session minutes, which were passed out earlier.
Move to approve.
Second. We have a first and a second. All those in favor?
Aye.
Any opposed? Next is the regular session minutes. I'll ask for a motion to approve those.
Second.
We have a first and second. All those in favor of approving the regular session minutes? Aye. All those opposed? Motion carries. And we are to reports. And first up from the Claremore Service Unit is Marty Smith. You are up.
Morning, everyone. Guess I'll start off by talking about one award that Claremore received for a large facility award for. It was actually a GIPRA award for managing the A1Cs in diabetic patients, or it's a measure we use to determine how well the patient is controlled. So they received an award in Oklahoma City at the GIPRA award ceremony for that. Under accomplishments, one thing I listed because it is a huge accomplishment to finally get our administrative physician on site for the OB program. If you'll remember, we were under a hiring freeze for almost a year with the OB program, and it took us from like mid-April until I believe it was September the 2nd to staff that position. But I think you'll see some good things happening with our new director of the department. In addition to that, our staff actually became, at one point we had 2 regular employee physicians out of 8 in that department. So it has a tremendous impact on patient care because, as you know, most of those types of patients like to see the same physician during their prenatal care and if possible even during when they deliver. So in addition to getting Dr. Hilliard there, we recently, since after I did this report, we also selected 3 nurse midwives. So we have 3 nurse midwives coming to the service also. So that's going to bump our staff from a staff of 2 regular people to we're going to add 4 more, so we'll have 6 out of the 8 positions filled. For dental program review, it turned out really good. Our dental staff is doing really well. Once again, we have 1 vacancy in that department, and then we have 2 vacancies that have been frozen by Oklahoma City in that department. But Dr. Bob Smith come and reviewed the program. he told me that they had the most efficient program, the measures they used to measure efficiency, and that they had the most dental visits of the IHS dental programs in Oklahoma, even though they were actually down 3 physicians. As far as new initiatives, this is one that I've never mentioned that we plan to participate in. It's a teleophthalmology project where ophthalmologists will be assisting us with the retinal screenings of diabetic patients. They'll be remotely doing that with some equipment that we'll install there at the hospital. The costs of that are very minimal. We already have the network backbone to support it, so there's several other sites nationally that participate in that program. As far as additional announcements, this week we brought in a new surgeon for the surgery service, so that will we've been at 50% staffing on the surgery service with only 2 surgeons. This will be the 3rd one, so we need to fill 1 more and we'll be full staff again in surgery. We had 1 week that was really good for recruitment. We actually had a surgeon and a family practice doctor and a nurse midwife all visit the facility in the same week. Pretty sure the nurse midwife will probably be there working with us, and we're still working on the surgeon and the family practice physician. On the downside, Merritt Jensen, one of our nurse anesthetists, been at the facility for over 15 years, or approximately 15 years, be leaving. He's retiring. And we have an anesthesiologist that's going to the private sector. So once again, with a small staff of 4, that's going to reduce our staff by half. And we're already recruiting for another anesthesiologist, and we will supplement the service with contract providers until we can get it restaffed. Deployments. I mentioned in here that we had 3 deployments, but actually the physical therapist has not been deployed yet. They kind of surprised me to see them at work because I thought they had already been deployed. They were notified, but they're still in a standby status. So we just have 1 nurse and 1 pharmacist that's deployed to the hurricane area. I mentioned a few weeks ago that we had an Eagle Scout that had volunteered to do a project to our glassed-in area at the center of the hospital, and that's been complete. I was actually on vacation and received an email from one of our staff members telling me how nice it looked, and I hadn't seen it at that point, but he really did a good job, and hopefully I'll get a letter out this week thanking him, and Kara will probably contact the news people about it too, get his picture. The legislators tour, it was August the 27th. I actually left off 1 person. We had 4 representatives from 4 legislators that came to Claremore. We had Senator Emhoff, Senator Coburn staff, Congressman Boren and Congressman Sullivan's staff that came to discuss the jurisdictional issue and security issues at Claremore. And I've subsequently been contacted by Headquarters East to update them about what we're currently doing with that issue. And Kara was there. She heard what basically the feeling that I got from it was that they were going to go back and look at potentially proposing legislation that would try to address the jurisdictional issues so that we could get better security protection for both our staff and the patients at Clarendon. I have not seen any correspondence to date on that from any of the legislators. On the workload, as you can see, we're still down in several, pretty much categorically in visits. I was working on another report yesterday, and I was evaluating our vacancy rate. I noticed in January our vacancy rate was right at 30. Our vacancy rate of medical staff providers, and most of them directly see patients. People like anesthesia and that sort of thing, they kind of support the surgeons and the OB docs and pediatricians and that sort of thing. But in general, in January, our vacancy rate of those types of providers was right at 36%. As of yesterday, it was right at 26%. Keep in mind, we just picked up 2 providers, one of them this week and one the first week in September, so it really has kind of been still hovering at 30%. We're going to pick up 3 nurse midwives and lose 2 anesthesiology people, so we're going to have a net gain of 1. But basically we've had a lot of luck with recruitment. We've got, like I said, in surgery, when we get 1 more surgeon, we'll be back up to staff. The problem with things like visits, you're not going to probably be able to see the benefits of that for something like 3 to 6 months. I don't know what the timetable is, but in my mind, there's a direct relationship between the number of doctors that you have seeing patients and the number of visits that you have if they remain productive while they're at work. So hopefully we'll see that situation improving. Just like in the OB department, when you're using 6 contract providers and you're rotating them through and you spend 2 or 3 days training them when they get there, and they're there for a couple of weeks or 3 weeks, and then you go through the same drill, and we hope that by staffing the department, in the OB department in particular, it may take literally months or years for that particular department to come back up to the level of, the patients are going to have confidence in the service, and I think they will, when the word gets out that we have the same staff, good staff there, there'll be more patients coming back to that service. In the outpatient area, it's just a matter of having enough providers to see all the patients. And I don't have a good explanation on the admissions other than admissions kind of follow outpatient visits, especially ER visits. The more ER visits you have, you'll intrinsically have more admissions. So I don't have any better explanation other than our goal is to get the hospital staff to the full staffing and then see what the impact is on visits. I'm anticipating, that we'll probably end up the year with something like about 170,000 outpatient visits. As far as collections, if we add in, we're probably going to be close. The year-end close after we add in September's probably be right at 11 million would be my best guess at this point. Since I've done this report, the CHS activities, we have the advised amount and the obligations. We had several approvals that had not been obligated through the software, so those have all been obligated out now to actually a zero balance, so that the obligations match the amount of money that we've been advised through the CHS system. I was asked a question earlier today if we received any chef funds. We've actually submitted about right at $1.5 million in chef cases, which is a lot because of our case manager that we hired about a year ago. But we've received about $777,000 to date on chef cases. And that's pretty much my report. I'll be glad to answer any questions.
We have any questions?
Question.
Yes.
When you obligate the contract health, do they take into consideration that they've got Medicare or Medicaid, and it's really not going to be $50,000? It's really only going to be $4,000 or $5,000.
I believe, and Dr. Mobley's sitting in the room, but I believe they're obligated to use Medicare rates now. That's correct. You know, these hospitals are obligated to only whatever they charge, they have to accept the Medicare rate.
Well, but I understand that. But what I'm asking is, when your contract health obligates and says this child has to have a stent, do you have what our contract is for a stent is what you obligate, or do you back off what Medicare is going to pay and those other things when you obligate it?
As far as I know, we only obligate what Medicare charges are, not twice that. Because Medicare is only about half of the total.
Well, but many times if it's a Medicare patient, even though we send them contract health, there's really no fee to the contract health. Medicare pays it. And I'm just saying, if you're obligating those dollars, maybe you really have more dollars to obligate and you're not at zero.
Yeah, I'll have to probably just to answer it with any certainty. I'll have to respond. I can respond by email within the next 24 hours to that.
Okay. I mean, just check it and make sure, because Hastings was doing that at one time.
Right.
Or, I mean, we at the tribe were doing it that way. And then we found out that we were obligated funds that were coming back to us, because when it's all said and done, third party paid some of it, Medicare paid some of it, and I think it made us much more efficient when we started not obligating the $50,000 every time we put somebody in the system.
Yeah. I understand what you're saying, but like I say, in order to accurately answer it, I'll respond within 24 hours on that.
Councilor Fulbright.
Hi.
I'm still wanting an answer to his question. He asked, and it can be my question now. The question was, do the Contract Health Committee take into consideration whether they are going to approve it or not? Like when a person comes in and they've got Medicare and a third-party supplement, so they're really highly insured and they still get turned down. I mean, do they take that into consideration, who they're going to approve if they are insured, and is it going to cost our system a whole lot of money, or it is not? That, to me, that's what I want to know the answer to.
Yeah, I think they always consider alternate resources, but once again, I can, it's kind of a twofold question that you're asking, and I'll answer both sides of it accurately.
Well, he just kind of brought it to my mind because the man called me really late last night, and I'm sending the email to Diana Turtle, but he said, I was turned down for rotator cuff surgery, and I've got this kind of insurance and that kind of insurance. And his son told him, why don't you just go to River Valley Orthopedics and get it done? You're insured. And he said, well, I was going to let them make the money. So I don't understand it, you know. So that's what he was wanting to know. Could he appeal it? And I said, well, you can appeal it.
Go ahead.
The RHS system is based solely on priorities, and we do not take into consideration any resources, because we're the payer of last resort. Of course, we're going to use all resources first, but as far as the priority system, it does not address anything other than in times of lack of funding, they pay down to the lowest priority. Invariably, someone says, I was turned down for lack of funds. That's never the case. It's due to the priority system. We don't have enough money to pay down to like priority 4, for instance. So.
Okay, you've answered my question. I think I directed it to the wrong people, because really what I was talking about was Cherokee Nation contracting somebody out to a private orthopedic surgeon. So I'll talk to somebody.
Councilor Calvin Watts.
Yeah, I think it's very important just to make sure that all minds are clear that whether it's Cherokee Nation Contract Health or Indian Health Service Contract Health, the ability to pay is not taken in consideration in determining who gets contract health services. It is based on medical priority, period. The folks that review it are blind to who that person is and if they have any resources, purely based on whether it's a life or death decision and some of those things as they get down to funding and availability of funds. But I know at Claremore Indian Hospital, we're lucky if we have funds to treat just life and death, pretty much situations which are immediate life and death. Never, even in Cherokee Nation Contract Health, would you consider if somebody has resources or not to make a medical determination on whether they get contract health. So I would hate that we would leave the room thinking that that might be based on finances available. I just think we have more flexibility in how we administer our contract health program at Cherokee Nation than Indian Health Service does, so we're able to get down further and we have tribal funds. But there's a great amount of concern. Why I originally raised my hand is that at Claremore Indian Hospital, the IHS at Claremore Indian Hospital has been less successful in retrieving third-party revenues than Hastings and Cherokee Nation, and it's something that we're looking at on the board. But any input from this council would be greatly appreciated because it is an ongoing struggle. I mean, I think we got lucky that we'll clear about over $10 million this year in third-party revenues, whereas Hastings is over $30 million. I think Hastings has a higher patient load than we do, but it's not too much different, right?
They
So just sheer volume?
Well, volume and demographics. And, like a lot of our patients, because of our location, like if you have a Medicare patient in Hastings, they have not Claremore Regional, whatever, the city hospital. And then they have Tulsa. Well, I guess Muskogee they have a hospital in Muskogee. Part of our problem is twofold. I think you'll find we don't have as many people on third-party resources, and the ones that we do, we're competitive with the hospitals in Tulsa. It's like some of our patients a lot of them actually live in Tulsa. So if they have third-party resources, they have a choice of whether to come to Claremore or go to a place in Tulsa. So, in the long range, we have to offer them either better service or more courteous, better service and be competitive with the private sector hospitals because we're in a very competitive environment, that geographic location.
Councilor Calvin Watts, is that all you have?
Yes, thank you, Mr. Chair.
I wanted to, we talked about this. I'm not blindsiding you with anything. And I have no illusions about federal health system versus private. I come from a private practice situation. And I'm in no way, shape, or form trying to trying to put a private practice medical situation on a federal system. But you just said yourself that I'm going to paraphrase, so correct me if you meant something different. You're in a competitive market, and this is going to require some different thinking.
I agree completely.
You're in a federal system, but you're in a competitive private practice market, and you're competing for third-party revenue. And you've got the people that you do have there, you've got good people. I have no illusions. I've said this before. I don't think that, and I could be wrong, but sometimes I don't think that people outside the tribal council realize how many calls we field from constituents. And I can tell you that about 75% of my calls on a daily basis are, why did the Cherokee Nation deny my contract health? My next question is, where do you live? Well, I live in Nowater, or I live in Claremore, or I live in Bartlesville. Well, the Cherokee Nation didn't deny your contract health, the federal government did. And that's a 10, 15-minute conversation with 20 people on a daily basis. I have no illusions that you don't have enough money. I've had the privilege of being in Washington, D.C. at Health and Human Service meetings, and I understand the budget deficiency. But let's get back to your original statement of this is going to, and my statement being this is going to take some different kind of thinking. Because like it or not, you're a federal health system competing in a competitive private practice market. And I've sat here for a year, and every single month, the only thing that seems to be up is the new charts. Every single outpatient is down, adult admissions is down, newborns is down, year-to-date collections is down. And I'm looking at 120 days, hoping that at least maybe that's up, and that's where some of it is, but you're only at 3%. My point to you is, you are in a competitive market, like it or not, and you are hamstrung by some federal rules. But at some point, you're going to have to just bite the bullet, and somebody's going to sit down and come up with some kind of plan to compete in this competitive market. Because I'm going to tell you, and I'm trying not to imprint private practice philosophy on the federal system, but again, to some point, you are operating in that system. If I'd come with these numbers from my practice for a year, I wouldn't be coming anymore because I'd be out of business. There's no way you can keep coming and everything's down all the time. So I guess my hope is that you are having some staff meetings with I mean, I know you've got good people there, and I know they're working hard, and I know you're hamstrung in the federal system, but I just hope that your staff is having these conversations of how do we, what advantages do we have, what can we bring to the table to compete in this Tulsa market. So I guess that's my statement and question to you is, are those conversations taking place? They
are in our department heads meetings, and just in general, like I say, unfortunately, time will tell if staffing. Like I gave someone the example the other day, and I'll repeat it. I've already said it since I've been here, but our surgery staff was 50%. Our OB staff 25%. Family practice is kind of back up now to where we're close to being. I'm not sure how many vacancies we have in family practice, but at any rate, we should be seeing some changes in those numbers. And I know it's been, since I've been around, it's been since mid-January to now. The OB service was, we were not allowed to hire anybody until mid-April or late April. And it's sad when it takes that long to get somebody in the door, from April till the first week in September. But, once again, on that particular service, that's a little different one. I think that even when it's staffed, you're going to see some numbers changing. We need to look at that carefully and give you more of a, like a 3-month snapshot versus a year-to-year. Give you both snapshots to where you can tell if we're turning the corner, because I really believe that we're turning the corner on recruitment. You know, I think we hit bottom on recruitment. Now we have to turn around the visits. And if you turn around the visits, the revenues will follow. And that's something that we have a little control over from our benefits coordinator's standpoint. And we're looking at maybe adding another 1 or 2 benefits coordinators.
Okay. Well, I appreciate it, and I said we did talk before. I wasn't blindsiding you, but
it's a legitimate criticism,
and I appreciate it very much. Are there any more questions? Thank you. Oh, well, Councilor Soap and Councilor Baker.
Not a question. No.
Oh, okay, Councilor Soap.
No,
Councilor Baker, now ask my question.
He actually has something else.
I've got a motion after this is done.
Marty, recently, I'm sure you're well aware that in District 6 we had an outbreak of a bug, let's call it. And I'm just curious, this question probably extends to Ed and Melissa as well, but I'm just curious as to what types of preparations did Claremore make in the escalation of all the aftermath of once it was known that there was a problem and this is happening. And could you kind of enlighten us on that, and also kind of just provide awareness or discuss, is there any further preparations being made, as when you look at it in hindsight and say, man, that was a pretty big deal. Could we handle another one of those types of situations, or are we going to be shipping people to Kansas City or something like that to be taken care of?
Well, Dr. Mobley might have to chime in on this, but from my point of view, I know we worked with the Oklahoma State Department of Health to identify. I think we did see how many cases. I'll let him tell you about that.
Well, we immediately admitted 2 and 1 child. We later transferred out. The area epidemiologist has been in daily contact until the day before yesterday, and they went off the daily updates. But of course, we work with the public health. As far as any terrorism or bioterrorism or any other biological epidemic, we have a plan in place to deal with such an event, and we've actually had practice drills and things like that. But we have it's really predicated more on bioterrorism, but if it turned out to be something like this, it'd be the same, bringing in the health department and everything.
So in your opinion, did things go smoothly, and do you think we've handled it appropriately and adequately?
Well, we only had 2 actually that presented, but yes, I believe we look for things like that all the time. We have an infection control department that looks at all the, in fact, public health nursing also is Cherokee Nation, and they also are involved in looking at infectious diseases such as hepatitis and all the STD type things. And so there's a couple of different departments that look at infectious diseases, monitor those, and report them to the state health department. So there's a lot of interaction between hospitals and the health department and our area.
You saw 2 cases that were identified
and admitted.
And did both of those transfer out, or just one?
No, one was a child, and they didn't respond very well, so we went ahead and transferred them to Tulsa, and then the adult did respond to.
Thank you.
Are there any more questions regarding Claremont? Thank you. Councilor Baker.
Yes, I should have done it just a tad earlier, but Charles Hoskin Jr. has sent a resignation and asked to be removed from the roles of this committee, at least for now, and I put that in form of a motion.
Second, with a friendly amendment to make it effective at the beginning of this meeting.
Please.
So he's not on, because I think that'd probably be the intent.
We have a motion to accept Councilor Hoskins' resignation from this committee effective at the beginning of the committee.
So he's not absent this meeting.
So he's not absent this meeting. All those in favor?
Aye.
Any opposed? Motion carries. Next, from Hastings, we have Ed McLemore.
Skulle ligga down här dåligt då har sig. Och så snarare hästar när det startar när det är slaviskt gäss. Mr. Chairman, members of the committee, I appreciate the opportunity to present our report. It's kind of sparse this morning in terms of items on our report, and I apologize to Council Member Fishing Hawk. We didn't meet our deadline on the 10-day advance submission of the report. However, we'll try to do better. I do have some items aside from the printed report that I would like to bring to your attention. The refills by mail program, we went live June 24th, and I'm saying 2,500 plus patients signed up. We think it's about close to 3,000 now. And of course, all of the savings that accrue to patients from not having to come to Hastings to actually physically pick up those medications is a benefit, indirect, in some cases very direct, to a lot of patients. We've received numerous favorable comments from people. Why we've not done this sort of thing before is just a matter of, I guess, oversight on the part of our folks. And but it's a good program, and we would encourage you to let folks know that this is available to them, and we'd be happy to enroll more. My right-hand man for the last 5 years, Keith Barrett, Deputy CEO, retired on September the 3rd. He had some, I don't know, something calling him, I guess, toward Colorado, the fishing streams or something up there. I don't know what it was, but he kind of just weighed the, wear and tear at Hastings on an individual, or, just the freedom of fishing every day up at in Colorado. I don't know that he made a bad choice. And Mitch Thornbrew has stepped in as our acting administrative officer, so if you have any questions related to the administrative functions, Mitch will entertain those whenever you would like to get in touch with him. After about a 4-year effort, and then we've finally gotten the final title opinion from the Attorney General of the United States, sent to the Secretary of Health and Human Services, Mike Levitt, signed last Friday on the 8.5-acre land purchase that cost us $250,000 for 8.5 acres. The Attorney General of the United States had to give his final stamp of approval and in a final title opinion on that 8.5 acres, and it was kind of astonishing to us that it takes that kind of action to effectuate a little land purchase on behalf of Hastings Indian Hospital. But that's the process that the federal government goes through to acquire real property. If you have questions from constituents about food service at Hastings or snack bar, it's going to be closed. The vendor up there is a subcontractor through the a program at the state level, and upon assumption of operations by the Cherokee Nation has some alternative plans, more healthy options available to patients and employees that are going to be available effective October 1st. So somewhere between the 25th and 29th or so of October, we expect the snack bar to close. So there may be a couple of days where we'll have to figure out some alternative for those patients who have to spend an inordinate amount of time at Hastings. And they're very few because people are typically in and out, and you don't have to worry about lunch any longer as you probably had to in the old days. I would like to invite all of you to the community building on September the 20th. It's a Saturday. It's for our annual powwow. It's the 6th annual powwow. Hastings staff, Hastings employees put that on. It's an event to recognize some of the accomplishments of people at Hastings. The area director vacancy is still hasn't been filled. The vacancy announcement closed on the 29th of August. We have not yet received the specifics about the process for the selection of the area director. In the meantime, the former CEO at Hastings, Hickory Starr, will continue to be the area director in Oklahoma City. Our transition ceremony, the assumption ceremony, whatever you want to call it, is being planned for October the 1st. Melissa may have further comments about that, but we think it's going to be at about 10 o'clock, starting at 10. There'll be a flag type ceremony, changing out, the PHS and installing symbolically denoting the assumption of operations by the Cherokee Nation, and certainly all of you are invited to that also. I was just recently advised that we do have some fairly immediate plans for October 1st and shortly thereafter. One of those is that we're going to institute a 24/7 pharmacy service that we have not had up to this point. A lot of that responsibility is rested on the shoulders of our nursing staff, and that's created a little bit of an issue with our Joint Commission accreditation standards compliance. And so we're going to correct that, and I think with the cooperation of the Cherokee Nation Pharmacy Program, we're going to be able to do that with the existing staff and some shifting around. Also, and the last item I have is if you have questions about Columbus Day, we've done some considerable thinking about how we accommodate the recognition of the holiday by the federal government and our IPA and MOA staff at Hastings, and the non-recognition or non-recognition of the holiday by the Cherokee Nation for direct hire staff, and I'm one of those, or will be October 1. I'll say something about that in a minute. So we worked out how that's going to affect everybody, and department heads are providing specific information to individuals. Clinics will be open. Hastings will be open. The entire facility will be open on October 13th on Columbus Day. It'll be under Cherokee Nation operation. Those IPA federal employees will be required to work if they are in essential positions, direct patient care positions. Now, if the department head determines that they're not going to be absolutely necessary for direct patient care, they will be given the option of taking that day off with their federal holiday pay. So that's to be determined by the department heads. And the last thing I'll say is that September 30th is going to be my last day as a federal employee. I'm going to retire effective September 30th. And then immediately on October 1, I'll be a brand new Cherokee Nation employee in the same position as the CEO in Hastings. I know some folks are overjoyed with that, and some folks kind of wonder about how this thing worked out. But anyway, for your information, I'm going to be a Cherokee Nation direct hire employee effective October 1.
Congratulations.
I'd be happy to answer any questions.
Any questions? We have one. We have two.
I'm shocked. I never saw that coming.
Do I take a small bit of Councilor Jordan?
Did I hear right that Dr. Felzine's going to leave?
Yes, Dr. Felzine has taken a position with the state of Georgia, I believe it is, or maybe South Carolina.
It's Georgia.
I think it's in Georgia, close to South Carolina. I think it's a small town, but he's going to be a director, I think, of a 14-county regional public health service, more or less, in the state of Georgia. He is a board-certified infectious disease physician, and he's just opted to take on those kinds of challenges effective, I think, sometime in around the middle of October, I believe.
Ed, how many doctors are we short up there?
I couldn't tell you right offhand. We are short a number of docs, but I think we've got we've just recently staffed up, as a matter of fact, in the ER, the emergency room, and I think we've got maybe 3 docs down in the internal medicine, the adult medicine clinic, and I don't know of any others. Let me, Dr. Nolan, do you have any idea about 2 in the adult medicine? And 2 doc positions in internal medicine, I guess. I thought it's 3, but.
How are we in the little kid area? We still okay?
Yeah, peds, yeah. Now, we're okay in terms of staffing for the space that we have available, and of course there are requirements. I mean, we have needs beyond what our space allows at this point, and so to answer your question in a short way, we're staffed up for existing capabilities, I guess, or capacity.
Any more questions? Councilor Baker?
Yeah, and I see where Barrett retired. Is he going to be a new employee, or is he gone, or what's that?
Well, I think for the time being, he's just opted to be out of the system completely. Now, we may have some old requirements where he may be of assistance in some aspect, like in the Cherokee Nation lab system. He is a certified lab supervisor. He was a lab supervisor before he became the administrative officer, and he's maintained his credentials in that area. So he may offer some technical guidance for the entire Cherokee Nation health system in terms of strengthening our lab system. But right now, I don't think any of that has been actually worked out. I think we'll be actually advertising for that vacancy once we do a Cherokee Nation PD and get the announcement out.
Any more questions? Well done. Okay. Next, from Cherokee Nation Health Services, we have Melissa Gower, and I know Melissa and her staff have been working extremely hard behind the scenes on something that's going to be relevant to my colleagues from Sequoyah County. So at some point I'll let you discuss that.
Good morning. Just want to announce that, as you all know, we've been Cherokee Nation Health as a what I'm calling a facilitator of a process to bring dialysis to Sequoyah County. We've been working with C&B, with other dialysis companies trying to get dialysis brought to Sequoyah County as a facilitator. And we've been working on that for a while now. And just before I came over here, and actually before I say that, there are currently there are three avenues that we're working on trying to facilitate that process. One of those is with Tahlequah City Hospital. The second one is with DaVita Dialysis, and the third one is with By Choice Dialysis. The last two, DaVita and By Choice, are both working on proposals to submit to Cherokee Nation businesses, and hopefully they'll have those submitted by October 1 so we can see what those are and evaluate them. But the announcement is that we've made some progress in the first one, in that Tahlequah City Hospital, of course, when you do dialysis, you have to apply for a certificate of need through CMS, and they applied for that and was denied. They reapplied, and we helped them get letters of support. I sent one, C&B sent one, and we got them some others. Sent those in, reapplied on July 15th, and this morning CMS faxed the letter and they got approved for their certificate of need. So that's a big milestone. The process from here is that the state survey agency has 6 months to survey them, and CMS to give them a Medicare billing number, and then proceed on. So it's still a ways in that process, but that is a big milestone because we weren't sure that we would be successful in helping them get a certificate of need, which is really hard to get. So we're excited about that, and Councilor Fulbright and Councilor Thornton, I know, are excited about that, and we're glad that we actually had a concrete announcement to give you today. So there is some big progress in that area, and I think that we've been sending some updates to try to keep you updated on that. And as soon as some of those meetings are scheduled, we'll let you know when those are, and would welcome your participation in those. Also, I think Ed did mention that, and the communications department, the event planning, is planning an event at Hastings on October 1st, and it is tentatively scheduled for 10 o'clock, and I'm sure that they'll send out all the information around that as soon as they have that completed. So if you can, you might want to go ahead and mark your calendar if you plan on attending that and participating. Also, I was told yesterday, and I don't have anything formal or an invitation, but I'm sure the communications event planning will do that, but I was told, and I've gotten a lot of questions about this, that the timeline for the Seminary Recreation Center to open is October the 1st, and they're planning on having some kind of a grand opening event there on October 14th. Don't have times or any more information other than I'm just giving you a heads up of, if you want to put those events on your calendar. I've submitted my report. I'll be glad to entertain any questions that you have about that. And that concludes my announcements.
Madam Speaker.
In Jack Brown Center, Deborah Johnson attended the Healing the Wellness Court activity in Adair County. What was the result of that? What did she learn there, or why did she go, and then what did she learn?
I don't know the answer to that. I'll have to get that to you.
Okay. That's one program I
Okay?
think's a good program.
It's a great program. I'll be glad to do that.
Thank you.
Any questions? Thank you.
You're welcome.
Oh, Counselor Jordan has one.
Melissa, do we have a plan in place to try to replace those docks up at Hastings?
Yes, we have a plan. I mean, we have a plan for all of our vacancies in our system. And just a positive comment, I was discussing something with one of the directors at Hastings the other day, and they made the statement that they had had more interviews with physicians in the last 30 days with us recruiting than they'd had in 5 years under Indian Health Service. So I think that's a nice compliment that I need to pass on. But I think Dr. Nolan would be glad to tell you that he's interviewed several physicians, and we have several coming more for interviews. And so, yes, there is a plan. Of course, the two that are vacant, and Dr. Felzine, as you mentioned, we were really sad to see Dr. Felzine go. He's been a real asset to our health system. He had signed a letter of intent and had planned on becoming a tribal hire. And so it had nothing to do with the transition. It's just that, you know, he's an infectious disease, that's his specialty, and it's something that is near and dear to his heart. And I think he was just offered a dream position for an infectious control physician, and, you know, weren't able to compete with that. So there wasn't any negative feelings on him leaving, other than we're very sad that he's leaving. And then there's another physician that's had some medical issues that's out. So those are the two vacancies. It didn't have anything to do with us not being able to respond.
How does our pay compare with other facilities of our type? Are we pretty well at the top end, middle end?
Well, what we try to do is to be very competitive, and every 3 years we do a salary survey for all of our medical professionals on our salary schedule. And we just finished that in, I think, May or June of this year. And so we did that, and we implemented a new salary schedule that's effective October 1. And I think that's part of, you know, we're very competitive. And that's part of, you know, one of the reasons why we've been able to bring physicians in.
Are we offering any sort of sign-on bonus or anything?
We don't offer a sign-on bonus. We did do that at one time, but it proved not to be as an effective. Our issue is not really, our biggest issue is not initial recruitment, it's retention. And so we do have a retention bonus.
Any more questions? Councilor Buzzard.
Yeah, Melissa, on third-party collection, do you expect that to match 07's collection?
We anticipate it to be a little more.
Okay.
I think last year we ran, I don't know the exact numbers, but it was 16-something million, and I think we're shooting for 17.
Okay, thank you.
Any more questions? Thank you. Next on the agenda, we're to old business. There appears to be none. New business, we have Kellen Palmer from the Veterans Administration. I would entertain a motion to permanently remove that as an agenda item.
So moved.
I'll second. We have a first and a second to remove Mr. Palmer from the VA system as an agenda item. All those in favor, say aye.
Aye.
Any opposed? Motion carries. Next, we're to announcements. Any announcements? Councilor Buzzard.
Yes, I have an announcement for our housing work group. We're going to meet about 11:15 today. Anybody wants to say what we're going to do? We're going to have a few sandwiches in, so once we get hungry, we can eat. Thank you.
Councilor Soto.
Yeah, I just wanted to say that I saw on one of the billboards as I was driving into work this morning and it asks the question, and it says, are you a fountain or are you a drain? And I thought that was a pretty neat question. And so you might ask that of your employees and reports, just as kind of a thought-provoking idea, is just to think about it. Are you a fountain or a drain?
Very good.
Councilor Callan Watts.
And after the meeting adjourns, could we be reminded who's on that housing subcommittee or work group or whatever?
I'll let Councilor Buzzer.
Could we find in here?
Members of
Who's members of that work group?
I don't know, we have to find the list. I think there's 6 or 7 that are on that work group. And we'll have to pull the minutes to find it, here.
Any more?
I want to move to adjourn.
We have a first and second to adjourn. All those in favor, aye. Any opposed? We are adjourned.